Ultrasound examination of the pelvis reveals a bulky uterus consistent with the postpartum state. The uterus is enlarged in size, which is a normal finding following delivery due to residual myometrial hypertrophy, increased vascularity, and involutional changes. The uterine outline appears smooth, and the myometrial echo texture is homogeneous without evidence of focal lesions such as fibroids or adenomyosis. The endometrial cavity is centrally located, with normal thickness for the postpartum phase, and no evidence of retained products of conception or abnormal echogenic material is noted. The cervix appears closed, and no significant cervical or intrauterine fluid collections are identified. The pouch of Douglas is clear, with no free fluid detected. Overall, cystitis is an inflammation of the urinary bladder, commonly caused by bacterial infection, but can also be related to irritative, chemical, or interstitial causes. Ultrasound serves as a useful, non-invasive modality for evaluating the bladder and detecting features that may suggest cystitis. On ultrasound, the bladder wall often appears diffusely thickened, typically measuring more than 3 millimeters in a well-distended bladder. The wall thickening may be uniform or occasionally irregular, depending on the severity and chronicity of infection. In acute cystitis, the mucosal surface may appear hyperechoic due to edema and inflammatory changes. Increased vascularity of the bladder. Wall may also be detected with color. Doppler imaging. The bladder lumen may demonstrate echogenic debris or suspended particles, reflecting pus cells, sloughed mucosa, or inflammatory exudates. In severe cases, clots or layering material can be visualized. Post-void residual urine should be assessed, as incomplete emptying may predispose to recurrent infection. In some patients, localized focal thickening can mimic bladder mass. However, correlation with clinical symptoms and urine analysis helps in differentiation. Chronic cystitis may lead to trabeculated bladder walls and reduced bladder capacity. Ultrasound also helps to exclude associated pathologies such as bladder calculi, diverticula, or obstructive uropathy. Although ultrasound cannot definitively diagnose cystitis without clinical and laboratory correlation, its findings such as wall thickening, luminal debris, and irregular mucosa provide strong supportive evidence in suspected cases. This makes ultrasonography a valuable adjunct in diagnosing and managing cystitis.